Hi everyone, I'm Ruth Lee. So I'm the neck cancer dietitian for the area. So as Mr. Thakkar said, I work across the whole patch. So I work from the other far end of Dorset all the way down to seeing patients in Portsmouth. So quite a wide area. I try and whiz around a bit to different places, but often I catch up with people quite a lot on the phone. So I know there's some people on here that I've never actually met in person, but I've spoken to on the phone a lot. So come and say hello to me, because I won't know who you are. My role actually at the moment is funded by Planets, which is incredible. And it's meant that kind of patients across the whole area have been able to get treatment for their diet and their bowels, which a lot of other net centres don't have. So I think that's been a really positive thing. So I'm going to talk about I decided to just do a bit of everything today. So I'm going to do kind of, people sometimes just at the start say, what can I eat? What can't I eat? We're going to do that. We're going to talk a bit about carcinoid syndrome. We're going to talk about the somatostatin analogues and the problems they can bring up. So that's your monthly injections. We're going to talk a bit about bowel obstruction. So for some people, the tumour can block their bowel. We're going to talk a bit about that. Then we're going to talk about pancreatic surgery and bowel surgery, because often I'll see patients after these kinds of surgeries and they can run into a few problems. So, as I said, what can I eat? People will say to me sometimes. There's not a neuroendocrine tumour diet. That's not really how it works. There's no specific foods that can, cure your net, make it better. And there's none that are going to make it worse either, which I think is really important to know. For most people, we just recommend a normal, healthy, balanced diet. So, carbohydrates and protein at all your meals, at least 5 fruit and veg a day, lower amounts of foods high in fat and sugars, and plenty of fluid. And mainly, we want people to stay within the healthy body mass index BMI range. So that's a healthy weight for your height. And the healthy range is 20 to 25. I often encourage my neuroendocrine tumour patients to be more towards the 25, so you've got a bit of weight to lose. Okay. So, talking a little bit about carcinoid syndrome. So, this is only for patients that have the raised hormone levels, so the raised serotonin levels that Mr. Thakkar was talking about earlier. So you might have had a urine test or a blood test, and you've heard that you have high 5-HIAA levels. So these are the kind of patients that will be experiencing carcinoid syndrome, and this might be the flushing, the tummy pain, the diarrhea, and there are just a few little dietary changes we recommend if you are having those symptoms. And I've tried to make it as easy to explain as possible, but basically serotonin is what's being produced in large amounts, and serotonin is produced from something called tryptophan, and that's an amino acid, which is a building block of protein. So we do say increase the protein you're having in your diet. And the reason we say that is so you have more tryptophan available, and that will be producing the serotonin. You might need more protein because lots of it's being produced serotonin, so you need it for the rest of your body. The ways to increase that, you can make sure you're having protein with all of your meals. You can have protein-based snacks, sometimes protein in nutritional supplement drinks as well. Because a lot of the tryptophan is being used to produce the serotonin, so going this way, tryptophan is also used to produce niacin, which it has 2 names, so it's vitamin B3 or niacin. And because of that, you might have a deficiency in niacin, so vitamin B3, that's the theory anyway. It's really difficult for us to test if you have deficiencies like that. It's not like an easy blood test we could do like vitamin D. So normally we just recommend that people take a supplement that contains vitamin B3. So that might be a vitamin B complex. Your GP can prescribe that sometimes. Or it might be a niacin-specific tablet. There aren't that many of them available. I know that there are some health food shops that do them. But you need at least 40 milligrams a day. So that is quite a large amount for some of the B-complex ones that only have less of the vitamin B3 in them. And also, as I've got on there, is the trigger foods. So, talking a bit about the trigger foods. So, I think often people have gone online and they've read about trigger foods, and by this I mean foods that can make your carcinoid syndrome symptoms worse. So more diarrhea, perhaps more flushing after you've eaten the foods. People will have read about lots of different things, maybe some of these on here online, and they'll just be avoiding everything just in case. And actually that's not normally the way I start things. The normally way I start things is we include everything because we want everyone to be enjoying their diet and have as wide a range of foods as they can. And then if you think there is something that's making those symptoms worse, don't exclude it straight away. Maybe try it again and make sure you definitely think it is that that's making your symptoms worse. And only then I would exclude it. And if you do think, and if you do end up excluding quite a lot of foods, it's good to talk to a dietitian really because they need to check that you're still having a healthy, balanced diet. I'll just go through a few on the list. So often it's a large meal or a really fatty meal or a spicy meal or alcohol. I think though with those ones sometimes I'm a bit sceptical because even if you don't have a neuroendocrine tumour, that can make your bowels pretty bad, can't it? So which one is it? Who knows? Then there's also the foods moderate to high in amines. So I think the theory with these is if you eat a lot of them, it makes the tumour produce more serotonin. Not many people have said ones on these lists, to be honest, that cause their bowels to be worse. Or maybe it'll just be one or two. So in general, I find that people don't need to exclude most things. They can actually have a really, exciting and well-balanced and interesting diet. So, and there's going to be a recording that's put online as well, so you can always re-watch as well. So somatostatin analogues. Those are the injections, the monthly injections, the lanreotide or the octreotide injections that you get. Unfortunately, one of the side effects can be something called pancreatic enzyme insufficiency. So what on earth is that? Normally, your pancreas produces enzymes which help you break down your food. And unfortunately, the injections kind of interfere with this and they mean that your pancreas can't produce the enzymes quite as well. So this means that your food isn't broken down as well as we'd like it to be. The main symptom of that is that stools can be quite pale. So often people will say to me yellowy, creamy, grey stools. They sometimes can look a bit oily in the toilet bowl or be a bit smelly. Really often they're floaty and difficult to flush away. And the reason for this is there's some undigested fat in the stool. So that's what's causing the symptoms. I should say that this doesn't happen for everyone on the injections. We can't predict who it will happen for and who it won't happen for. I'd say it's probably over 50%. And some people it will just happen for the first injection and then they'll be fine afterwards. Some people will really struggle with their bowels for kind of 3-4 days after the injections and then be okay. And some people, it will really affect them for the whole time they're on the injections. So what do? We can definitely help with this. We really encourage people to get in contact with us. Because what we can do is we can give you some tablets which are pancreatic enzyme tablets. So they're just replacing the enzymes that you otherwise would have been producing yourself. So most people are on something called Creon. Some people are on Nutrizyme. Those are just 2 different enzyme tablets. They look like those little ones in the corner there, so it's a little capsule. I suppose the difficult thing is that you have to take them with all food and milky drinks that you have. So you wouldn't have to take them, with water or with tea or coffee with just a little splash of milk in, all kind of fruit or vegetables if you're just eating them on their own. But everything else, so milky coffee, even hot chocolate, meals, snacks, you need to take them with all of those things. We normally start people off on 2 with a meal and 1 with a snack or a milky drink. You take them just as you start to eat, right at the beginning with a cold drink. And we often do need to increase the dose past that, but we just start you off on the kind of basic dose. And how do you know you're taking enough? Well, it's when your stools have gone back to being a much more normal colour, consistency, and kind of not so frequent as well. And they do that pretty well for most of our patients. Obviously, it's really important to be taking them because they mean you're digesting all your food properly, you get all the nutrients out your food. it makes sure you get all the fat from your food. And some vitamins are soluble, so they're dissolved in the fat. So it's really important that you do take the tablets because they're making sure even you're absorbing your vitamins that you need. So the patients that are on the monthly injections at your kind of yearly review, part of the bloods that we look at are those vitamins just to check that you're not low in any of them. Okay. I just wanted to say a bit about bowel obstruction, as I think at the moment I'm getting more patients that are suffering with kind of going towards bowel obstruction. So it might be that you have a bowel neuroendocrine tumour and you're waiting for surgery, or it might be that surgery is not appropriate for you at the moment. And kind of what's happening is, so if you've got the bowel as a tube like this, the tumour might be just sort of blocking it a little bit. And some food could be adding to that blockage and, really getting blocked up, and you could be getting really painful tummies, not opening your bowels regularly. And we can do some things with diet to help that. So the first thing we normally say is, right, let's go on to a low-fibre diet. So I'm going to use sweet corn as an example. We all know that sweet corn just goes straight through. If there's a tumour and a sweet corn, and that blocks the bowel, that's why we say to reduce the fibre in your diet. So it's more things that aren't digested quite as well. So, peppers and things like that are going to risk blockage. Often we'll need to start being a bit more strict and really have a strict low-fibre diet. So the things we'd be asking people to avoid are any brown carbohydrates. So that's like your brown rice, brown pasta, brown bread. Bran-based cereals, then your beans, peas, lentils, nuts and seeds, and then also kind of fruits and vegetables, being quite strict on them. So skins, seeds, pips, stringy bits on fruits and vegetables, and trying to kind of cut those right down. I also think some people will have been told to go on a low-fibre diet before I speak to them, and they'll be avoiding, all fibre, being really, really strict, and they're really miserable because their diet is a bit boring and rubbish, and it's working with people to get the balance, still enjoying your food, still getting a wide range of things, but knowing that you could follow the perfect low-fibre diet and you could still get a blockage. So it's just letting people know the risks, and seeing what's the best way to go forward for them. Unfortunately, with a low-fibre diet, some people do still get quite bad symptoms, so it's often a lot of tummy pain. So we do need to kind of go to the next level. And I should say, you often move between the levels, so you might need to go for this one, go to this one, but then when your symptoms get a bit better, you might go back up again. And that's how this works quite often. But yeah, so you might need to go to kind of a soft or a puree diet, so things that are very, very smooth and easy to eat. And some people, unfortunately, often when people are waiting for surgery, they might need to go on a liquid diet just to kind of reduce that risk of any blockage. So liquid diet would be nutritional supplement drinks, milk, because it's quite a nutritious drink, soups, yogurts. Obviously not very exciting diets, but hopefully there's an end point in place. And you do definitely need to talk to a dietitian if you're on a liquid diet to make sure that you are getting all the nutrients around. So I'm going to talk a little bit about pancreas surgery and kind of the complications that people can get post-surgery. So I'd say that, there are different types of pancreas surgery, and the complications are going to depend on what you have. So some people will have more extensive surgery. So the Whipple surgery or total pancreatectomy, where kind of everything that's here will be taken away, apart from the very little tip of the pancreas here for the Whipples. Or some people will just need kind of the tail and the body taken away. So that's this bit here. So they're obviously going to have more of the pancreas left over. So some people, after pancreas surgery, do you remember I said the pancreas is what produces the enzymes? So if you don't have very much of it left, you might not be producing a very good amount of enzymes. So you'll get the similar fatty diarrhea to what you have with the injections. Almost everyone that's had a total pancreatectomy or oral Whipple's will need the Creon or the Nutrizyme tablets after that surgery. If you've just had the tail and the body removed, so the distal pancreatectomy, not that many people need them, but we do find occasionally people do, and it's just based on looking at your symptoms, looking at your stools. People often get a lot of wind, a lot of bloating, tummy cramps as well, and that can indicate that they might need the enzyme tablets. In terms of your vitamin deficiencies, again, it's those fat-soluble vitamins because you're not producing, you're not digesting the fat as well. So we'll check for them, and you might need some extra top-ups, or in fact, just going on the enzyme tablets often helps. And then some people, if they have the more extensive pancreas surgeries, can get diabetes afterwards, and that's because the pancreas also produces hormones that helps control your blood sugar levels. So unfortunately, some people do struggle with their blood sugar levels afterwards, and either your dietitian or your nurse or your doctor or your GP will be able to help with that and decide if you need to go on to medication or maybe insulin as well. Okay, so bowel surgery. I'd say this is probably the main area of my role, helping people after bowel surgery. It's really difficult because I think sometimes people will have had not very nice symptoms before and they think that surgery is just going to sort them out and they'll be just done for the rest of their lives and everything will be much easier. And actually, it is like that for some people, but other people really struggle with their bowels afterwards, and it can be really difficult to get them back to something that means they're happy with their quality of life. So that's why I spend, quite a lot of time working with people, trying different things and trying to get bowels much better. So I think the first thing to say is most people, almost everyone, will be put on a low-fibre diet after bowel surgery. Can be kind of 4 to 8 weeks, and the reason is just fibre bulks out the stools, makes them more frequent. And if you've had a join in your bowel from the surgery, it just means that everything, it's a lot lighter on your stomach, basically. So we'll do that until you've maybe had the sign-off from your surgeon, or maybe we've got to 6 weeks and everything sounds fine. I'll say, all right, let's start introducing fibre again. In terms of the complications after surgery, diarrhea is definitely the most common. It can be for so many reasons. So if I might not have spoken to you at all, and then you've had your surgery and I'll speak to you, and it could be, some things in your diet. So we would run through that, things like kind of caffeine and sweeteners, or lots and lots and lots of fibre. So I'll just kind of do a bit of an overview of diet. It can be if you're on the injections. It might have been that previously you hadn't been picked up, but you were having diarrhea because of the injections that we spoke about. It might be just due to the amount of bowel that you've got removed. It might be due to a couple of other things that I'm going to mention in a bit more detail, so the bile acid malabsorption or the small bowel bacterial overgrowth. Often we'll start with the diarrhea by putting you on some loperamide tablets, Imodium, it's another name, and that just slows everything down. But in general, I kind of like to think of them as a sticking plaster until we work out really why your bowels aren't too good, and then we treat whatever the cause is. Saying that some people, if you've had a lot of bowel removed, might always need to be on the loperamide tablets. So then wind and bloating, loads of people suffer with a lot of wind and bloating that I speak to. Sometimes it's just after the surgery, and then kind of things settle down, but often it's something that does continue on for a long time. Again, sometimes there's some dietary things that we can change. So kind of, often kind of your leafy greens or your broccoli or beans can upset things a bit. But then we also might go on to trying things like peppermint oil capsules. Or again, it might be some of the symptoms of the things I'm going to come on to talk about in a bit more detail. So vitamin deficiencies. Everyone that's had, so I should say that the most common surgery for neuroendocrine tumours is a right hemicolectomy. So that's where the end of your small bowel and the start of your large bowel have been removed. And if you've had some of the end of your small bowel removed, you should always have had your vitamin B12 checked at some point after your surgery. That's because the end of the small bowel is where that's absorbed. So often people will find that their levels are quite low afterwards. Your GP can just do an easy blood test for it. And normally your GP surgery will do injections. So I think you have a few at the beginning, but then you have them every 3 months. You can't take a tablet because you don't have enough of the right bit of bowel to absorb it. So it does have to be injections. We also keep an eye on your vitamin D and your calcium, because sometimes the levels of those can get a bit low after bowel surgery. So that's something that can be checked and replaced if needed, and those can be done with an oral tablet. So as I said, I'm going to go on to talk a bit more about those bottom two. So bile acid malabsorption, again, this is a big part of my job these days. I don't think I really knew very much about it at all before I started this role, and I've slowly learned more and more thanks to the experiences with all my patients, actually, and their feedback and just working with them to make their lives better. Bile acid malabsorption, it's completely horrendous, actually, from speaking to people. I will speak to people that have had their surgery 5, 10 years ago, and they'll have just been having their bowels open 10 times a day. And they think that's just because of the surgery and it's something they have to live with afterwards. And it's not. You don't have to, actually. You need to get in contact with people. We can make things better. And as I say, often it's this bile acid malabsorption, which I'll explain a bit about. So what normally happens is this green bit's your gallbladder, and that's your liver there. The liver produces bile. It gets stored in the gallbladder. And then if you eat something with fat in, the fat triggers the bile to be released. It helps digest all the fats in your food, so it's doing that all through this small bowel, the wiggly bit here. And then normally the bile is reabsorbed at the end of your small bowel here, obviously not by a big blue arrow, but then back to the liver, and it can be reused again. So if you've had that small end bit of your small bowel removed in surgery, like with a right hemicolectomy, you're not able to do that recycling of the bile. So the bile goes into your large bowel, travels around this outer bit, and it really irritates things. Draws water in, so you can start seeing the symptoms over there. You get really watery diarrhea. People literally say to me, it's like water. It gives you loads of wind and bloating, tummy pain sometimes, and it's urgent diarrhea. You need to rush to the toilet. Normally I have people that have accidents daily, unfortunately. So it's that kind of diarrhea. I should also mention that I have a good few patients now who have just haven't had the bowel surgery, but they've had their gallbladder removed as part of their surgery. And actually, that can give you bile acid malabsorption as well. I've read up a bit about it, and the theory is that you can't store the bile. It just slowly drips into the bowel, so you have a constant bile going into the bowel, and we think that just ends up being too overwhelming for the bowel, and it can't do the reabsorbing. So I have had a few people recently that's been the cause of their bile acid malabsorption, but because I'm speaking to so many people about their poo, I can recognise the little symptoms now. And it's the really watery, needing to rush to the loo, bowels opening overnight, burning when they're opening their bowels. Have I missed any? Oh, kind of, again, it can be kind of yellowy, greasy stools. So it can look a little bit like when I said you need the crayon, so that's a bit difficult sometimes if we don't know which one it is. So you've got these symptoms, what do we do about them? I quite like doing a CCAT scan, which diagnoses you definitively. So then we know that I said there's so many reasons people can have diarrhea after bowel surgery, and it's nice to know that actually you do have this or you don't have it. I don't want people to be taking more medications unnecessarily, because I know that a lot of my patients are on a lot of medications. So we do the CCAT scan, and it comes out with the vast majority of my patients have severe bile acid malabsorption when I put them through the scan, but it can be severe, moderate, mild, or borderline. And with most of my patients, because they're on the severe side of things, we do need to treat it with medication. The main medication that I choose to use is colesevelam. It's actually a medication that's primarily used to reduce your cholesterol, but it just happens to work really well for this as well. The difficult thing about it is it needs to be, you can't take it with other medications because sometimes it will inactivate them, so we just need to take it separately to other medications. So for people that are on a lot of things, it's hard to kind of fit it in, but we always kind of work together to make sure we can do that in a safe way. It works really well in general. Normally people tell me that they see improvements within a few days, or will increase the dose and it'll be within a few weeks. There are alternatives. There's one that's a powder that you mix with water, but people have told me it's like wallpaper paste, and it doesn't work as well, so that's why I just choose not to use it. But it does work well for people that find it difficult to take tablets, because the cholesterol tablets are big tablets. So we do the medication, but if you have more mild bile acid malabsorption, or if we do the medication and we're like, things have improved quite a bit, but there's definitely still room for improvement, we'll start looking at a low-fat diet. And by this, I mean, normally we get about 35% of our energy from fat, but we're trying to get down to 20%. So it is quite a relatively strict diet, and I think it does involve quite a lot of input from the patients, because they'll have to look at their current diet and work out how much fat's in it and maybe reduce that down. But I had a lot of people that have just had to make like a couple of changes, and they found that it makes a huge difference, or stay away from a couple of foods. People always tell me this kind of diarrhea is worse after, I think, fish and chips is the main culprit. Roast dinners, I can hear people going, yes, fish and chips. I think pizza quite often, or kind of anything that's deep fried or fried in a lot of oil. So whenever people are saying that's what makes my bowels worse, that's making me think that it's probably this bile acid malabsorption. Sometimes it does take a while of us working together and getting the medication right and getting the diet right. But in general, you know, we get away from that. I'm opening my bowels 10 times a day and having to run to the toilet to, you probably won't get back to what you would consider normal bowels, but if we get to kind of opening your bowels 3-4 times a day, and they're a bit more formed and brown, then I'm pretty happy, because it generally improves people's lives a lot. I just wanted to talk about small intestine bacterial overgrowth. This is something else that people can quite often get after bowel surgery. So, you know, I said in the right hemicolectomy, it's end of small bowel and start of large bowel. So normally there's a really nice little valve in between those two bowels, which keeps the contents of the small bowel in the small bowel, the contents of the large bowel in the large bowel. But obviously things can move through. The bacteria in the small bowel is quite different to in the large bowel. And if you don't have that valve anymore, then the bacteria can mix quite a lot more easily. And they can just get a bit out of hand, really. So you have bad bacteria and good bacteria in your bowel. But if you end up with too many of the bad bacteria, you can get, again, you can see the symptoms are similar. Diarrhea, wind and bloating, tummy pain. I should also say after the Whipple's pancreas surgery, you can also get this. I was trying to think of the best way to describe this without a picture, but we call it a blind-ended loop. So you end up really with a bit of bowel that food doesn't pass through regularly, so bacteria can build up in there. So again, the build-up of bacteria can cause this bacterial overgrowth. What do we do for it? So some places will do, I think it's called a hydrogen breath test. When I started this role, I spoke with some of the gastroenterologists who are the kind of people that would be in charge of doing these tests. And they're not very reliable tests. The results aren't that great. And they said to me they didn't really think, and from my reading as well, I didn't really think it was worth doing these tests. So we'll just think, you know, if it looks, your symptoms are like that and we have a cause for it, we will try doing these tests. We'll avoid doing those tests and we'll just go straight to treatment. So some of the things I normally try is probiotics. So probiotics are good bacteria, basically. There's quite a lot of different types of them around. It's hard to know which one to go for. The main things to look for is you want at least 1 billion bacteria per capsule. You want lots of different strains, so that's different types of bacteria. There definitely hasn't been enough research around these, so we don't know exactly which ones to go for, but Ones with bifidobacterium and lactobacillus are the ones that we know have the most kind of research around be helpful. The one I recommend to people quite often is called BioCult. It's the advanced multi-strain one. The reason I use that one is because there's 14 different strains, including those ones I mentioned. There's plenty of bacteria per capsule. You don't have to keep them in the fridge or anything like that, but also you can't get probiotics on prescription, so they're actually also quite reasonable in their price. I looked on Amazon, because everyone tells me that's the cheapest price to get them, the other day, and it was £12 for 60 tablets, so that's a month's supply. So I would suggest people normally try them for a month. You need to try them for that whole month to see if they help. And I say take 2 tablets every day for a month, and then we'll talk after that and we'll see if it's helped things. I'd say in general, probably over 50% of my patients do seem to get some benefit from them. It's often the wind and the bloating that seems to improve. Some people need to take them forever to get their continued symptoms. Some people can take them as a one-off and they get improved symptoms. Some people just need to take them every so often for a month maybe to get symptoms improved. The other thing that we can do is antibiotics. That might sound a bit counterintuitive because sometimes antibiotics give people diarrhea. But the antibiotics, they kill off lots of bacteria in your bowel, basically. So the theory is they kill off the good bacteria. And the antibiotics that's normally used is one called rifaximin. The difficulty is it has to be prescribed by a hospital doctor. So it would have to be through one of the doctors. And we try that for 2 weeks. Normally people get a quick response if they will be feeling better, but it definitely doesn't always work. And some people will find that they need to be on it constantly. And there's obviously risks around kind of being constantly on an antibiotic. So it's weighing those up. So I just wanted to put in a little bit about a patient feedback questionnaire that hopefully anyone that's had contact with me should have received over the last few months. I just wanted to do this to have a look at, how I was doing, how the service was going, but also importantly, my role is actually only funded. Planets wanted to set it up and get it going, but it's only funded until next year. So I need to get as much information and things to support my role for the NHS to take on the role next year. So I just thought I'd put a couple of the results up here. I think I sent it out to just over 200 people, and I just sent it to everyone that the NET dietitian has seen over the last 2 years. So that was either myself, or some of you might have spoken to Alexandra Capon, who covered my maternity leave. So this was one of the questions I asked. The care I received from the NET dietitian improved my overall health. So we've got you can't see it very well, percentage of patients down the side, that goes up to 40, and completely disagree, in between, agree, and completely agree. So as you can see, most of them are on agree or completely agree, so that's great. Most of the people who disagreed or were in between, they did write that it's because they'd only just started seeing me or we were kind of in the middle of trying things. So I think kind of we hadn't got to the end of their kind of pathway or story yet. But I was quite pleased with that. Then, again, in what way did the dietitian's care improve your health? Oh, sorry, it's a little bit small here, isn't it? But, for example, what we got along the bottom, we've got improved stool frequency, improved stool consistency. So it's a lot to do with bowels, but also helping people gain weight, because some people are losing a lot of weight. But then the ones towards the end are more to do with kind of quality of life, mental health, increased confidence going out the house. I wrote down a couple of the specifics here. And I should explain as well that the grey is if I helped a lot, and the purple is if I helped a little. So really it's kind of the top of the purples as to the people I helped, and that's 100%, and that's 0%. The blues is it's not applicable, because obviously not everyone needs their bowels improved, not everyone needs their weight improved, and the green is unanswered, so I imagine those are probably not applicable as well. So it's kind of really just the top of the purples that we'd be reading. And the highest one was 80% of people I helped with stool consistency, so getting their bowels to be more formed. But also 75%, they said they had an improved quality of life, and 50% I improved it a lot. Again, it was around 70% for help with stool frequency, stool colour, and confidence leaving the house. I think, for me, I was really pleased at those results because in my head, the reason I do my job is that people can live their lives more. They can, enjoy life, not feel like they have to stay in the house because they don't know when they're going to open their bowels. They're not out and about and always needing to know where the closest toilet is. And, that probably still will be in the back of a lot of people's heads, but if I can improve that and get people going out more, going on holiday, going out for meals with people, that is why I do my job, for me, to be honest. And I hope that I can keep on doing that side of things. Oh, I just always put this in at the end. Mark always laughs at me because I always tell him to take his vitamin D. Everyone should be taking vitamin D. Everyone in this room, because you live in the UK. I don't know why I put sun on there, because the reason we're taking it is because there's no sun. Basically, in the winter in the UK, there's not enough sun. It's not the right wavelength or something clever. October to March, everyone should be taking 10 micrograms or 400 international units. They're just 2 different measurements a day. You might be taking more than that because perhaps your levels are low, and that's absolutely fine. But everyone should be taking at least that amount per day. And that's everything. Thanks for listening, everyone.